Hello, welcome to part 2 of the presentation of Pharmacological Management of Risk Factors for Ischemic Stroke. I am Melissa Wu, pharmacist from SGH, together with Dr. Jasmine De Leon, resident physician at the Acute Stroke Unit of KTPH. At the end of the session, one should be able to identify the modifiable risk factors for stroke and understand the latest evidence on the management of certain risk factors to help in risk reduction for ischemic stroke. Hyperlipidemia and stroke. The relationship between hyperlipidemia and ischemic stroke has been demonstrated in studies, particularly for large artery atherosclerotic and lacunar stroke subtypes. This graph demonstrates atherogenesis. 20% of LDL goes to the peripheral blood and may be taken up by macrophages. This will initiate inflammation and eventually transform into foam cells, which induces migration and proliferation of smooth muscle cells and formation of atherosclerotic plaques. Atherosclerosis is a disease predominantly of the intima of large and medium-sized arteries and will lead to stenosis of the lumen, aneurysmal formation, calcification, ulceration, thrombosis, and thromboembolism, which is translated clinically into stroke and cardiovascular diseases. Statins have been proven to be beneficial in stroke in view of the following mechanisms. LDL cholesterol reduction leads to reduction in brain embolism in CHD patients. For example, reduction of left ventricular thrombosis with less myocardial infarction, blood pressure lowering effect, regression of carotid and vertebral artery atherosclerosis, and intima media thickness. It also has an anti-inflammatory effect. It has pleiotropic effect leading to plaque stabilization. It improves endothelial dysfunction, causing improved cerebral vasoreactivity. It has a positive effect on fibrinolytic systems and platelet function, and it also may have neuroprotection. In this table, the meta-analysis included 24 trials correlating the use of statin with stroke risk reduction. Incidence of all strokes was reduced by 18%. In a meta-regression analysis of all major statin trials, each 1 millimole per liter decrease in concentration of LDL cholesterol equated to a relative risk reduction for stroke of 21.1%. The SPARKLE trial is the only trial to date dedicated to evaluating the role of statins in secondary stroke prevention. 4,731 people with stroke or TIA were randomized to either receive oral atorvastatin 80 mg daily or placebo. The study results showed that there was a statistically significant reduction in stroke risk for the patients who received atorvastatin. Current evidence does not show a significant impact on stroke incidence when patients are given fibrates, niacin, or cholesterol absorption inhibitors. There is also no evidence to indicate a definitive LDL target for stroke patients. As a result, the 2014 stroke guidelines follow the 2013 ACC-AHA guideline on the treatment of blood cholesterol to reduce atherosclerotic cardiovascular risk in adults. In summary, statin therapy with intensive lipid-lowering effects is recommended when the stroke or TIA is presumed to be due to atherosclerotic disease, regardless of LDL level. Furthermore, patients with ischemic stroke or TIA and other comorbid atherosclerotic cardiovascular disease should be otherwise managed according to the 2013 ACC-AHA cholesterol guidelines. These guidelines state that as long as patients have a stroke and they are less than or equal to 75 years old, they ought to be treated with high-intensity statin therapy. If patients are more than 75 years old or cannot tolerate high-intensity statin therapy, treating with moderate-intensity statins is recommended. This table also from the 2013 ACC-AHA cholesterol guidelines, indicates which doses of statins are considered to be high intensity or moderate intensity. Therefore, after a stroke, unless there are contraindications, patients should be started on statin therapy. Diabetes and stroke. In Singapore, 1 out of 9 people aged 18 to 69 has diabetes. That's about 11.3% of our population, or more than 400,000 people. Chronic hyperglycemia is associated with micro and macrovascular complications leading to coronary and cerebrovascular events. Case control studies of stroke patients and prospective epidemiological studies confirm that diabetes mellitus independently increases the risk of ischemic stroke with a relative risk ranging from 1.8-fold to nearly 6-fold. Diabetes is defined as a fasting glucose of more than 7 millimoles per liter or 2-hour postprandial blood glucose of more than 11.1 millimoles per liter. Post-stroke hyperglycemia is associated with poor outcome and death due to increased blood-brain barrier disruption with higher hemorrhagic risk and lactic acid production in ischemic tissue leading to greater infarct size. Diabetes is associated with a substantially increased risk for primary ischemic stroke. There is also evidence that having diabetes can increase the risk for recurrent stroke, with one study finding an increased risk of 60%. However, there are no major trials for secondary prevention of stroke specifically aimed at patients with diabetes. Therefore, management of stroke patients with diabetes is based on evidence for non-stroke or mixed population. The 2014 stroke guidelines state that after a TIA or ischemic stroke, all patients should probably be screened for diabetes mellitus. Furthermore, the ADA guidelines recommend statin therapy for all patients with DM and existing cardiovascular disease including stroke, suggesting a target goal of LDL less than 2.6 millimoles per liter, with less than 1.8 millimoles per liter as an optional goal. In terms of glucose control, it is recommended to follow the current ADA guidelines, which state that a goal HbA1c of less than 6.5% may be appropriate in selected, mainly younger individuals if it can be achieved safely and without frequent hypoglycemia. Otherwise, it is reasonable to follow the target of HbA1c less than 7 to 8% for stroke patients.
In summary, hypertension, dyslipidemia, diabetes mellitus are known modifiable risk factors for ischemic stroke. BP control is important for both primary and secondary prevention of stroke. In acute ischemic stroke, the brain experiences dysautoregulation, thus, BP management must be managed carefully. Long-term BP goal for post-stroke patients is less than 140/90. Statin therapy is recommended to reduce risk of stroke. It is reasonable to target an HbA1c of less than 7% for risk reduction. Thank you for your time. We hope this presentation helped you to understand the latest evidence for management of risk factors such as hypertension, hyperlipidemia, and diabetes mellitus with stroke.